Hola, ¿cómo están? Bienvenidos a Uroconect, Voces de la Urología colombiana, en este nuevo capítulo desde Panamá con un invitado internacional, el doctor Matthew Smith. Él es oncólogo, es profesor de medicina en Harvard, además trabaja en el MASS en Massachusetts y también trabaja como director del Bertucci Center de Cánceres Genitourinarios y pues ha sido autor y coautor de múltiples estudios en cáncer de próstata. El doctor está aquí hoy para darnos una gran primicia, vamos a hacer una revisión de un artículo publicado recientemente, apenas el 12 de octubre, y del que se hizo presentación inicial en ESMO de este año. Entonces, welcome, how are you? Thank you very much for being here with us in Uroconect.
I'm very happy to be here.
Thank you. This is the podcast of the Colombian Society of Urology, and we wanted you to share with us some insights about the Aranote, this new study and trial that was presented at the ESMO meeting this year.
Happy to do so. It's a very important study.
Thank you. The first question I wanted to do is, could you please tell us about the primary and secondary endpoints in the study?
Yes, happy to do so. So the primary endpoint for Aranote was radiographic progression-free survival, and the study was designed and powered to address that endpoint. There were a variety of important key secondary endpoints, including overall survival, time to castration-resistant prostate cancer, time to PSA progression, time to an undetectable PSA, as well as, importantly, safety.
Which was the intervention in the study?
Patients in Aranote were randomized randomly to either an androgen deprivation therapy plus darolutamide or androgen deprivation therapy plus placebo. To increase patient and physician acceptance of the placebo-controlled randomized design, the randomization was 2-1 in favor of darolutamide.
Could you please briefly summarize for us the inclusion and exclusion criteria in the study?
Eligible patients in Aranote included those with metastatic, castration-sensitive prostate cancer. Importantly, metastases in this study were defined by conventional imaging criteria, meaning technetium bone scans, computed tomography scans, and or MRI scans. Patients had to have started their androgen deprivation therapy within 12 weeks of study enrollment, and the study included patients with an ECOG performance status of 0, 1, or 2.
Okay, something like that called my attention was why having a super scan was an exclusion criteria.
Sure, so let's first describe what a super scan is. So a super scan means that you have complete uptake of technetium by first pass. So you have confluent uptake of the technetium tracer in the bone. So you have extensive skeletal metastases. And this precludes determination of the primary endpoint of radiographic progression-free survival. So it really didn't make sense to include these unusual patients with extensive superscan bone metastases because you wouldn't be able to assess the primary endpoint of radiographic progression-free survival.
I saw that the study had very diverse geographic and also demographic characteristics, making it very representative. What do you think about that?
It is important, right? Because this is a global trial. So the results of this study, we believe, can be generalized to patients throughout the world. The Aranote did have global representation with many geographic regions around the world represented in a variety of ethnic and racial groups. So a very important feature of the Aranote study.
And what do you think about the fact that the comparison was with placebo?
So we know from prior studies that darolutamide meaningfully improves outcomes. We know this from non-metastatic castration-resistant prostate cancer, as well as the results of Arasens in metastatic castration-sensitive prostate cancer in combination with docetaxel. So the unmet sort of need or role here, the open question was, how can we define the effectiveness and safety of darolutamide as a doublet in metastatic castration-sensitive prostate cancer? To do so rigorously requires a placebo-controlled trial. I think it's a very supportable approach for really two reasons. One is that despite level 1 evidence of improved outcomes with intensification with an ARPI, many patients, in fact, probably most patients throughout the world, receive androgen deprivation therapy alone. So the control of ADT plus placebo is really globally representative of the common standard of care. And second, for many patients who enrolled in the trial, they otherwise would not have had access to an ARPI.
Which were the results of this analysis?
So very positive study. compared to the placebo group, patients in the darolutamide group had a marked improvement in radiographic progression-free survival. The hazard ratio was 0.54, meaning a 46% reduction in risk of radiographic progression or death. So a very positive study.
And about the safety profile, because we know the patients with prostate cancer mainly are elderly patients that use many medications. So about this, what do you see about the safety profile?
So safety is always important, and it's important for all of our patients, but as you point out, particularly important for our very common scenario of older, frailer patients, many of whom are on many concomitant medications. So again, safety is important for all of our patients, particularly important role in those older, frailer patients on lots of other medications. Consistent with the prior experiences with darolutamide in non-metastatic CRPC, as well as in combination with docetaxel and metastatic castration-sensitive prostate cancer, darolutamide had a very favorable safety profile. Rates of any adverse event, serious adverse events, or adverse events leading to treatment discontinuation were really indistinguishable between placebo and darolutamide. In fact, the rates of treatment discontinuation were higher in the placebo group than in the darolutamide group.
And about treatment-related.
Okay, yeah. So treatment-related deaths were uncommon and were not increased with darolutamide.
Do you think that using PFS is a good surrogate endpoint to consider this therapy and change our practice or our decision making in the future?
I really do believe so, right? We know darolutamide is a survival prolonging drug based on prior results from both Aramis and Arasens. With this study now, we see this compelling evidence of improvement in radiographic progression-free survival, very comparable to the best results of any other study of doublet therapy with an ARPI done in this setting with the outcome of radiographic progression-free survival. And there's been a consistent, strong relationship between radiographic progression-free survival and a variety of other important outcomes.
What will be your final remarks?
So, in my view, Aranote establishes darolutamide is an important drug in metastatic castration-sensitive prostate cancer. Darolutamide is not only effective as triplet therapy, ADT, docetaxel, and darolutamide, but also as doublet therapy, ADT plus darolutamide. It has shown meaningful improvement in radiographic progression-free survival, as well as benefits in all of the other measured secondary outcomes, including overall survival. And consistent with prior experience, darolutamide has a very favorable safety profile.
Okay, thank you very much, Dr. Smith, for presenting this important data to us. Gracias a ustedes por acompañarnos. Esto pues es muy novedoso porque tenemos como una primicia con este estudio y con el Dr. Smith que nos lo explica de forma tan sencilla. Entonces, para que tengamos en cuenta que probablemente haya pronto una nueva dupleta que tengamos a la mano para estos pacientes con cáncer de próstata metastásico hormonosensible. Y muchas gracias por acompañarnos. Nos vemos en el próximo capítulo de Uroconect. Chao.